Hello everybody, this is Eric with FlightBridgeED and welcome back. I'm going to start on the second podcast of our 12-lead interpretation, or our fundamental approach of 12-lead interpretation. And like I said in podcast number 1, we're not going into a prolonged lecture on 12-lead interpretation starting from scratch, but I did want to kind of hit on some fundamental aspects in podcast number 1, and we're going to kind of branch off into bundle branch blocks and Sgarbossa criteria and other imitators of the ACS. Acute coronary syndromes. So why don't we start off by talking about bundle branch blocks and understanding really what that is. A bundle branch block is a conduction basically in which there's a delay or obstruction along the pathway. This electrical impulse travels down and makes a heartbeat, and this delay or blockage basically that may occur on this pathway sends an electrical impulse to the left or right side of the heart, and it's delayed, and so it causes an abnormal beat, and that's where we have this identification of a bundle branch block. It's very difficult to determine if the patient with a left bundle branch block or right bundle branch block has an acute myocardial infarction, so that's why we're kind of discussing this. So let's talk quickly about bundle branch blocks. This can be a normal pathology. It could be a pre-existing condition, or it may be accompanied with acute coronary syndromes. Like I said, a few things to remember. This is a critical thing. You have 60 to 70% association of pump failure. So basically, our afterload is depleted, and we know that carries oxygenated blood to our brain and our tissues and our kidneys, and 40 to 60% mortality rate without reperfusion. So these are the candidates really when you look at thrombolytic therapy. All the studies and stuff have showed that thrombolytic therapy does have an increased mortality and morbidity rate. Catheterization via balloon angioplasty, things like that, is a better option, less risky. And so in these rural settings, if there's a new onset bundle branch block, or we've identified that this bundle branch block is an association with acute coronary syndromes, it's really important that if there's thrombolytics available, this is one of those instances where you would want to give that. We want to remember that bundle branch blocks are real tough because they mimic ACS, and they can hide evidence of ACS. They have this nasty looking depolarization of the QRS complex, and it affects your ST segment. It causes what's called a discordant look, and so if you have a downward deflection of your QS segment, like in a left bundle branch block, what discordant means is that you would have ST elevation, and so you're going to have a downward deflection of your QS segment, and you're going to have this big tall ST segment, and that is obviously what we look at when we look at ST elevation in a normal 12 lead. We're looking for ST elevation, so it can make everything look really, really horrible. So we need to be able to identify in this setting, because it mimics and it looks so bad all over the 12 lead, when do we have an ACS or acute coronary syndrome, and when don't we? Again, it can cause ST elevation, it can cause ST depression, you can have hyperacute T waves, inverted T waves, and very wide pathologic Q waves. And again, it can hide those same things. So it's very, very troublesome. It's, again, very critical to reperfuse these patients as quickly as possible. Very high mortality and morbidity rate when this doesn't happen. So the reason why I wanted to talk about this podcast, or this topic in this podcast, is I think, like I stated in podcast number 1, I was always taught that left bundle branch blocks are mimickers. They're tough to identify ACS, which is true, and that they were kind of those outliers, and we wouldn't activate a cath lab or a STEMI alert for a bundle branch block because we couldn't identify if this was ACS related. So with this Sgarbossa criteria, I think it's brought everything to the forefront. It gives you an algorithm to be able to identify and facilitate a diagnosis of acute myocardial infarction, and I think it's excellent. So that's the whole purpose of this podcast, is to kind of bring this to light. Again, morbidity mortality is huge when we don't identify this quickly and get these patients reperfused. So let's talk about how we identify a bundle branch block. There's a few criteria, and let's go back to our basic EKG interpretation. We'll go back to our measurements. Your 12 lead is going to give you your QRS duration. It's going to give you a P to R interval. It's going to give you QTC segment duration, things like that. And we know based on our early education on basic EKG interpretation that our QRS duration is 0.04 to 0.12, and so anything greater than 0.12 or 120 milliseconds is going to be pathologic. And so you're going to hear me say physiologic and pathologic. Physiologic meaning a normal thing, pathologic meaning that that's bad, that we shouldn't be seeing that. So we want to identify very quickly if this is a pathologic or a physiologic QRS complex. So how do we do that? Well, like I've said before, and if you've ever heard me teach 12 leads, I'm very passionate about teaching based off anatomy, off the coronary artery, and how they're involved with preload and afterload and occlusion and trying to foresee problems in the future. So I think reading your 12 lead a certain way is very important. We should always be doing a systematic approach on how we read our 12 lead. So what I like to do is I like to kind of rule out a bundle branch block right away, because that's our main mimicker that we could see. And so what I do is I go straight to V1, and they've shown through research and trials that V1, which is your first septal lead, is diagnostic for a bundle branch block. So I'm going to look at my QRS duration on my measurements on my 12 lead. You remember, if you don't have that, you're going to count your little boxes. So greater than 3 little boxes for your QRS segment is going to be pathologic. And if I see that my duration is greater than 0.12 or again 120 milliseconds, then I know that I have a bundle branch block of some sort. Then I need to identify if this is a new or old bundle branch block, or start that process based on history. And I need to look at my V1 lead. And so imagine driving a car from right to left along that isometric line of V1, and if you would turn your blinker on to turn left, you would have the blinker go down. And so if you see a downward deflection, and what you're going to see is a QS segment, if you see that and you have a pathologic duration of your QRS complex greater than 0.12 milliseconds, you know that you have a left bundle branch block. So your blinker's down, you're driving from right to left, you turn your blinker, you push it down to turn left, and in that instance, that's going to be a left bundle branch block. And we use the same concept for a right bundle branch block. You're driving along from right to left on that isometric line, and we turn our blinker up, and that's going to be a right bundle branch block. So you have to have greater than 0.12 milliseconds on your QRS duration, and you have to have it in V1. And so, I think the big mistake that people see is remember back in the day we saw these rabbit ears, and we didn't do 12 leads in the field, and we'd see these nasty rhythms on a standard 2 or 3 lead EKG tracing. And we got to remember that that's in monitor quality. That's not diagnostic quality. And so the monitor does not look at that as crisp. It doesn't look at it as perfect, and we can't ever diagnose ST elevation or anything in monitor quality. We always have to do a 12 lead to be diagnostic for ST elevation MIs and bundle branch blocks. So V1, look at your QRS duration, identify if it's left or right. Okay, so that's all great. We've identified that we have a bundle branch block. So how does Sgarbossa criteria come into play? Well, back when I first started doing this, we used this was an exclusion criteria. If you had a bundle branch block, you were told that you couldn't identify if this was an MI. And we know based on literature and by studies and research that the mortality and morbidity rate for left bundle branch blocks is significantly high, 40 to 60%, if not reperfused pretty quickly. So these patients were kind of being left out. It's not that we weren't treating them. We were treating the symptoms of the cardiac event, but we weren't getting them to the most appropriate facility. We weren't getting them to the cath lab and on the table within that 120 minutes, like is standard. So we would take them into the ER, or we may not take them to a definitive cardiac hospital, because of our protocols. And so in 1996, Sgarbossa and some colleagues of his did a trial, and they looked at left bundle branch blocks and AMI patients, and they derived 3 criteria that helps diagnose the hidden AMI in the presence of a bundle branch block. Unfortunately, I didn't hear about this until mid 2000s. I mean, this took a while to get out to the EMS community and things like that, and I still think it's very new. I don't hear it taught very often, so that was one of the prefaces that I wanted to put this out in a podcast and kind of get that out there. So here's the 3 different criteria, and it's based on a points criteria. So the first thing is you have to have ST elevation greater than 1 millimeter concordant with a QRS complex. So what does that mean? Well, like I said before, you have standardly you're going to see a QS segment, so you have a downward deflection on your QRS complex in a left bundle branch block, and you're going to have ST elevation that's going to be discordant, so it's going to be opposite. That's what discordant means. And you're going to have ST elevation that's going to be real large, right? And that's where we mimic or that imitates that ST elevation. In association with the Sgarbossa criteria, if you have elevation greater than 1 millimeter concordant with a QRS, so if, for instance, you had a right bundle branch block and so we have that upward deflection based on our criteria. Remember, we turn our blinker up or to the right, and so we have the upward deflection of our QS complex. If you had associated or concordant ST elevation with that of 1 millimeter, that is predictive of AMI. Okay. Same goes for ST depression. If you have ST depression greater than 1 millimeter in leads 1, 2, or 3, or V1, 2, or 3, so your precordial leads, your anterior leads, and you had a bundle branch block, so you have a QS segment going downward, and you have, instead of ST elevation, like you would normally see that's discordant, you would have concordance. So what that means is you're going to have your downward deflection of your QRS complex, and you're going to have ST elevation or ST depression. It's going to match it. It's going to mirror it. It's going to be right alongside of it. So that's concordant. So concordant is bad in this setting. So if we have ST depression greater than 1 millimeter in leads V1, 2, and 3, then that is indicative or predictive of AMI. The last thing is if you have ST elevation anywhere on your 12 lead, in just one lead, greater than 5 millimeters, so that's going to be a massive ST elevation that's discordant with the QRS complex. For instance, if you had lead 3, let's say, and you had a QS complex and you had massive ST elevation, like you would normally see, that we would normally have in a standard 12 lead without a left bundle branch block. So you're going to have ST elevation greater than 5 millimeters that's discordant with a QRS complex anywhere in the 12 lead. That's also predictive of an AMI. And that last number 3 criteria is probably the least definitive for diagnosis. And they give each one of these a point system. And the point system basically just gives you a higher probability. So the first one, having concordance of ST elevation greater than 1 millimeter, positive with a positive QRS complex. So in a right bundle branch block, for instance, if you had a right bundle branch block and you had the ST elevation that's greater than 1 millimeter or 1 millimeter, that's a score of 5. If you had a concordant ST depression, let's say in a left bundle branch block that's 1 millimeter, you would have a score of 3. And then if you had excessive discordant ST elevation, so this is where we have discordance in leads with negative QRS complexes. Let's say you had, again, lead 3 in your inferior leads that showed this massive ST elevation greater than 5 millimeters. That gives a score of 2. And I'm not going to get into the percentages, but just know that these are predictive, and it just gives us that high index of suspicion. And so Sgarbossa, made this criteria. It's been utilized, it's been proven, and I think the big lesson here is that we have a criteria to go by, that these patients with new onset left bundle branch blocks with associated acute coronary syndromes aren't getting missed, and we're getting them into the cath lab and we're treating them as aggressively as we would a standard normal 12 lead with ST elevation. So that's really important. I am going to put a patient scenario on the forum regarding this. I'll put multiple 12 leads with Sgarbossa criteria and the different aspects that I think people will enjoy, and we can discuss it more in the forum. I'm going to continue on and kind of talk more about other imitators that we may see, and we'll kind of wrap up this podcast. Some other imitators we may see is ventricular rhythm. So we have a few of them. We have paced rhythm, obviously. I talked about that a little bit. And so I think something to remember, when I started in EMS in 1992, the pacers were large. They were up in the chest. You could see them. And when you did your primary assessment, you could see those things. Obviously, we want to be doing a good history. We want to be asking our patients a lot of questions to try to identify if they have a pacer implanted. But nowadays, the pacers are very small. They're put in the chest. They're put in the side of the stomach and the axial area, and so they're in different spots, so they're easily missed. And then the other part of that is the pacer spikes are really, really tiny. Sometimes it's extremely difficult to see that, and you may see this 12 lead that looks horrible, like it's got global ST elevation, or there could be different leads that have ST elevation. And I think this is what I've seen clinicians miss the most, is they've misdiagnosed 12 leads or ST elevation MIs because of paced rhythms. So just take real good care of doing a good history, looking at your 12 lead, trying to identify those pacer spikes, whether it's AV paced or ventricular paced, or it's both, 50-50 AV ventricular paced. Just look real closely, get a good history. And most patients are probably going to tell you, or their family is going to tell you. Obviously, ideal ventricular rhythms are going to be real wide and nasty. VTAC is going to look horrible, and obviously PVCs. So, the other one is left ventricular hypertrophy. So what is that? So remember what I talked about. I talked about in podcast number 1, we have our left ventricle, we have the Frank Starling effect, and we have that excessive stretch based on prolonged hypertension. And, our pumping of the heart increases because of the resistance, and this causes chronic overfilling. So we have the stretch, we have the chronic overfilling, we have the muscle that's growing larger, and so we have this very enlarged heart. And what this will show up on the 12 lead, it will show up as these massive QS segments that will kind of go down into the next row. So if you look at your 12 lead, you have V1 and 4 and 3 and 5 and so forth. And so in V1, that QS segment is going to go all the way down into the V4, the V3 lead. And there's a criteria to look at that. And basically, what you're going to do is you're going to look at your R waves. You're going to count your R waves. You're going to count the big boxes, and you're going to look at, let's say, V2 and V5. You're going to add those up and add them together, and if it's greater than 35 millimeters, you have left ventricular hypertrophy, and that's all good. So is that going to change your treatment? No, it's not. It's just something to identify, and when you see it, it's going to be obvious. You don't really need to count the boxes. Again, it's not going to really change your treatment. It may tell you their disease process is farther along than maybe in other patients, or they may have some cardiogenic shocks susceptibility based on their MI. They may not compensate as well, things like that, but it's not going to really guide your care too much. This can also mimic things, though. It can cause ST elevation, depression. It can cause real inverted T waves and tall T waves. So, just like a butter branch block, this can mimic an MI in multiple ways. A few other things to think about is pericarditis. Pericarditis is something that isn't super common, but it's something that we're going to see in patients with viral diseases, or that they've had the flu or things like that. They might start having chest pain, and just unrelieved by anything. The one thing that may relieve some of the discomfort is them leaning forward, and they're just taking that pressure off of the pericardial sac, and they're unable to lay supine. So getting good history and getting a 12 lead on these patients, and you're going to see global ST elevation that kind of doesn't match the anatomy. If you remember in part 1, I said that we do everything off of anatomy. We look at our coronary arteries, and that should match, the occlusion should match what we're seeing on the 12 lead, and that's going to guide our care. In pericarditis, you're going to have global ST elevation that just doesn't make sense. It doesn't match your anatomy. So you're going to base this again off of your history and the patient presentation and kind of get an overall assumption. Another mimicker is called benign earlier polarization. This isn't very common. It's very rare. I did see this one time in, I think, 2002, and it tricked me, and I was teaching 12 leads quite a bit at the time. And basically, you're just going to have this fish hook looking thing that comes off of the S wave and between the ST segment there, and it just looks like ST elevation. And the patient may or may not be symptomatic. This is a normal thing for them, and it's seen in patients that are 20 to 40 years old, and it's predominantly seen in black males. So just kind of keep that in mind. Things to remember: imitators can produce ST elevation or depression. They can eliminate ST elevation and depression, and we need to really weigh on our clinical findings based on our pertinent negatives, our approach to care, and our assessment. That's huge. As far as the Sgarbossa criteria, use these criteria with caution. None of these criteria are perfect, and so there to help you maybe identify those tough patients that would be missed. And the big one to remember is that number 3, where we see the ST elevation with discordance of the QRS greater than 5 millimeters. This can exist in asymptomatic patients with left bundle branch blocks because of the concurrent left ventricular hypertrophy. So if you identify that you have a patient with LVH and you see this, it could be a normal thing. So don't get all wound up. I think just always weigh on the side of caution. If you see this, utilize the Sgarbossa criteria. Put these patients as a STEMI alert. Activate a helicopter if you're out longer than 30 minutes. And we should always be doing the best thing for our patient. So that's all I have for this. If you have any questions regarding this Sgarbossa criteria or have any feedback, please email me at eric@flightbridge.com. You can go onto the website, you can leave a comment, or just go onto the forums page, and when we put this up here as a patient scenario with the different topics, and we can discuss it there. But I really enjoyed doing this, and I'll talk to everybody fairly soon with other podcasts. And remember, you can follow us on Twitter, and we have set up a Twitter account. It's FlightBridgeED. So follow us on Twitter. We'll be posting new podcasts and things like that, and new news. And thanks for all your support.